All right, buckle up, everyone, because today we are diving into a topic that's, well, it's pretty intense, to say the least. We're talking emergency chemotherapy, and not just in any setting, but in the ICU, specifically for hematological cancers.
Yeah, you could say that again. It's definitely a high-stakes area of medicine.
Yeah.
You've brought in some fascinating research on this kind of niche area.
Definitely niche and definitely intense. We're talking about situations where even the slightest delay in treatment it could have devastating consequences. This isn't your routine chemo appointment.
Not at all, no.
Nah.
This is life or death stuff happening
Yeah.
right there in the ICU. You were talking about the research you shared, the 2024 review from Intensive Care Medicine.
Exactly, that's the one.
Yeah, it really underscores the complexity of the decisions doctors face in these situations. It's they use the phrase double-edged sword, and honestly, that's a perfect way to describe it.
Double-edged sword, huh? So it's not just about knowing which chemo drugs to use, it's about understanding the whole patient, their overall health, how the cancer is affecting their body, and how they'd even react to aggressive treatment when they're already so fragile.
You hit the nail on the head. And that's precisely why this area of medicine requires such a, I guess you could say, a delicate dance between different specialists. You've got your intensivists, the critical care experts, and of course you have the hematologists who are, well, they're the blood cancer specialists.
Teamwork makes the dream work, right? But even with the best care in the world, I can't imagine the mortality rate for these patients is very encouraging.
Yeah, you'd be right. The review, it actually cites studies showing that 25% to 32% of patients with hematological malignancies, those who need emergency chemo in the ICU, they unfortunately don't make it.
Wow. Those are some heavy statistics. It really drives home just how serious these situations are.
No doubt about it. But amidst those numbers, there's a glimmer of hope. Yeah. The 12-month survival rate, it hovers around 30%. And get this, some patients even achieve complete remission.
So it's not entirely hopeless. Sounds like choosing the right patients for this kind of intervention, that's got to be crucial. You wouldn't want to put someone through that if the odds were stacked against them.
Absolutely. Patient selection is, well, it's paramount. You have to weigh the potential benefits of trying to eradicate the cancer against those very real risks, especially when a patient is already so vulnerable. That's where that collaboration we talked about, the critical care folks working hand in hand with the hematologists, that's everything. It's about, I'd say, it's about giving them the best possible chance, not just to survive, but to have some quality of life as well.
So it sounds like we're dealing with this kind of two-pronged battle, right? You've got these aggressive cancers, and then you've got the body's own response to the disease, which can create a whole other set of emergencies.
That's a great way to put it. It's like the cancer itself is throwing fuel on the fire, creating these urgent situations that require immediate attention.
And those situations, those are what often land these hematology patients in the ICU in the first place.
Exactly. And the review you shared, it actually breaks down some of these, you could call them cancer crises that can pop up.
Cancer crises. Okay, that sounds a little ominous, but I'm definitely intrigued. What kind of crises are we talking about here?
Well, one common one, and it's a bit of a mouthful, is called hyperleukocytosis and leukostasis.
Hyper what now? Okay, I'm going to need a translation on that one. Those sound like something out of a medical textbook.
Fair enough. But they're actually not as complicated as they sound. Hyperleukocytosis basically just means there are way too many white blood cells in the bloodstream.
Okay. And that's a problem because,
Well, think of it like this. Your blood vessels are like highways, right? They're responsible for transporting oxygen and nutrients throughout the body. Now, imagine those highways suddenly become jammed with cars. Way too many cars trying to squeeze through at once.
gridlock. That's no good.
Exactly. And that's essentially what happens with leukostasis, which often goes hand in hand with hyperleukocytosis.
Yeah.
You've got this excess of white blood cells, particularly in acute leukemias, that creates this traffic jam in the bloodstream.
So the body's trying to fight back against the cancer, but it's almost like it's overdoing it, creating this log jam of white blood cells that can't get where they need to go.
Precisely. And as you can imagine, this backup can cause some serious problems, especially for organs that require a constant flow of oxygen-rich blood, like the lungs and the brain.
Makes sense. Those are pretty vital organs.
Understatement of the year, right?
Right.
And when those organs are deprived of oxygen, you start to see problems like respiratory distress, neurological issues, even bleeding. It can get very serious very quickly.
Okay, so we've got this white blood cell traffic jam wreaking havoc in the body. What's the solution? Just blast it with chemo to try and wipe out those excess cells.
You wish it were that simple. Unfortunately, it's not quite that straightforward. You see, before you can even think about using chemotherapy to tackle the root of the problem, you've got to clear the traffic jam first.
Ah, so it's like calling in a tow truck before you can even start directing traffic.
Exactly. And in this case, that tow truck is what's called cytoreduction. It's a way to quickly reduce the number of white blood cells in the bloodstream to restore normal flow.
So kind of like hitting the reset button on the body's defenses, giving it a chance to breathe, literally, while you figure out the next move.
Right. And there are medications that can do that, bring those white blood cell counts down quickly. In really severe cases, they can even use a process similar to dialysis to filter those excess cells directly from the blood.
Wow. It's like they're pulling out all the stops to get things back on track.
They absolutely are.
Ah.
But as if that weren't enough, there's another curveball these cancers can throw, and it's called tumor lysis syndrome, or TLS for short.
Okay, tumor lysis. I'm not sure I like the sound of that. What exactly is going on there?
Imagine this. You've got these cancer cells that are, for lack of a better word, bursting open, spilling their contents into the bloodstream.
Oh, that sounds messy. And probably not great for the body in general.
You got it. It's messy, and it can be incredibly dangerous. You see, the stuff inside those cancer cells, it's toxic in high amounts. We're talking about things that can wreak havoc on the kidneys, mess with your heart rhythm, even potentially cause seizures. It's bad news.
So, in a way, it's not even the cancer itself directly attacking the body at this point, but rather the fallout from those dying cancer cells.
Exactly. And here's the kicker. It can happen spontaneously as the cancer is growing, or it can actually be triggered by the chemotherapy itself.
Hold on, so the treatment itself can actually worsen this whole tumor lysis thing.
It's a real catch-22. But the good news is that doctors are usually prepared for this possibility, especially if they know a patient is at high risk.
So what's the game plan then? How do they stay one step ahead of this tumor lysis syndrome?
It's all about being proactive. They'll use aggressive hydration, closely manage electrolytes, and administer medications to try to counter those toxic byproducts that are flooding the system. And again, this often means a stay in the ICU where they can keep a close eye on the patient's organ function and intervene quickly if things start to go south.
It really highlights how crucial the ICU is in all of this. It's like this safety net that allows doctors to push the boundaries of treatment, knowing they've got backup if things go sideways.
You said it, but we're not done yet. We've got one more crisis to cover, and this one involves a system that's absolutely vital, but often taken for granted: blood clotting.
Okay, so like when you get a cut and your blood clots to stop the bleeding, that kind of clotting.
That's the one. But now imagine that system going completely haywire. That's the essence of disseminated intravascular coagulation, or DIC for short.
Haywire how, though? Too much clotting, not enough.
That's the thing. It can be both. You can have uncontrolled bleeding on one hand and excessive clotting on the other. Neither scenario is good, and both could be deadly.
Okay, that sounds terrifying. I'm guessing this ties back into cancer somehow.
It does. You see, certain types of leukemia, they can really mess with the body's clotting system, sending those clotting mechanisms into overdrive.
So on top of battling the leukemia itself, some patients are also dealing with their blood either clotting too much or not enough. Talk about adding insult to injury.
It's a harsh reality for sure, and once again, it highlights why that multidisciplinary approach we talk about, having both the hematologist and the intensivist working together in the ICU, that's absolutely essential in these cases. The treatment has to walk this tightrope, addressing the immediate clotting problems while also going after the root cause, which is the leukemia itself.
A two-front war, essentially. You mentioned treating those immediate clotting problems, but what about the leukemia itself? Does chemo factor into that side of things?
Absolutely. Just like with the other crises we've talked about, getting that cancer under control is paramount to resolving the DIC in the long run. Sometimes doctors have to prioritize managing the bleeding or the clotting before they can safely give chemo, but ultimately it's about tackling both fronts.
So it's a balancing act, weighing the risks and benefits at every turn. We've covered a lot of ground here, and it's been pretty heavy. We've got white blood cell traffic jams, toxic spills, and a clotting system gone rogue. And something tells me these aren't even all the curveballs these cancers can throw, right?
You're right. We've only just scratched the surface. There are a number of less common but equally serious complications that can arise, and they all require that same level of expertise and aggressive management in the ICU setting.
So for anyone listening who might know someone battling these types of cancers, what's the key message you want them to take away from all of this?
I think the main takeaway here is that while these cancer crises we've been talking about are serious and, frankly, pretty scary, they're not insurmountable. Modern medicine, especially in these specialized settings like the ICU,
Mhm.
has become remarkably adept at handling these situations.
It's reassuring to know that there's hope, even when these complications arise. But it also sounds like the ICU itself plays a pretty crucial role, not just for the chemo, but for all the supportive care that goes along with it.
Yeah, it really does seem like the ICU becomes this lifeline for these patients, offering not just the chemo itself, but this whole other level of support that they might not get anywhere else.
It's a great way to think about it. It's like, when you think of the ICU, you often think of it as this scary, high-pressure environment. And while it's definitely intense, it's also this incredibly protective bubble for these incredibly vulnerable patients. It's about constant vigilance, being able to respond in an instant, and having, I guess you could say, having an arsenal of tools and expertise ready to tackle any challenge that comes up. So when you say constant vigilance, what are we talking about specifically? What are the doctors and nurses keeping a close eye on?
Pretty much everything you can think of. Vital signs, of course, things like heart rate, blood pressure, oxygen levels, keeping tabs on kidney function, the whole 9 yards. Because remember, these patients are, well, they're teetering on a very fine edge. Things can change on the fly. And that's where the ICU really shines. It's a 247 operation. Someone's always got their eyes on the monitors. So if even the slightest thing starts to go out of whack, they can catch it and address it immediately.
It's like having a team of, I don't know, highly trained bodyguards, but instead of protecting against physical threats, they're protecting the patient's body from itself, right?
That's a pretty spot-on analogy. And if something does go wrong, which, let's be honest, it can happen, the ICU is equipped to handle it in a way that a regular hospital ward well, it just can't.
How so? What makes the ICU so uniquely capable of handling these kinds of complications?
Well, for starters, there's the equipment. In the ICU, you've got immediate access to ventilators if a patient needs help breathing, dialysis if the kidneys are struggling, medications to stabilize heart function. You name it, they've got it. It's all about having those tools right there, ready to go at a moment's notice to manage those potential crises as they pop up.
So it's not just about treating the cancer in isolation. It's almost like they're having to maintain all these other bodily systems at the same time just to keep the patient afloat while the chemo does its thing.
You're absolutely right. It's a delicate balancing act, to say the least. But it's not just about having the equipment, it's also about knowing how to use it effectively. And that's where the human element comes in, the expertise. We're talking about a whole team of specialists. You've got your intensivists, your hematologists, nurses, pharmacists, respiratory therapists, all these different disciplines working together, coordinating their efforts to manage these incredibly complex cases.
Teamwork. The recurring theme seems to be emerging again.
It really is.
Yeah.
And the ICU, it's set up in a way that fosters that kind of collaboration. It's about communication, knowing what the other team members are thinking, anticipating problems before they even arise, and being adaptable enough to switch gears and adjust the treatment plan based on how a patient is responding. Because every patient is different, every cancer is different, and there's no one-size-fits-all approach.
So we've talked about the terrifying complications. We've explored the vital role of the ICU in providing that high-stakes care and buying precious time for these patients. As we wrap things up here, what's the big takeaway you hope people walk away with after listening to all of this?
That's a great question. At the end of the day, I think this whole conversation really highlights the strides we've made in medicine, both in terms of critical care and hematology. While facing a life-threatening complication from a blood cancer, it's undoubtedly one of the scariest things someone can go through. But there's always hope. With the right care, with those highly specialized interventions that we've been talking about, even in the direst of circumstances, survival is a real possibility. Some patients even go on to achieve complete remission. It's remarkable.
It sounds like, as you said earlier, it's a high wire act for sure. But with the right team, the right environment, it's a walk these patients don't have to take alone.
I couldn't have said it better myself. And speaking of advancements, you mentioned earlier that there are some new treatment options on the horizon, things that could potentially revolutionize the way we approach emergency chemo in the years to come.
We did touch on those briefly, those novel therapies that seem to be generating quite a buzz in the oncology world. Things like CAR T-cell therapy, targeted therapies, they seem to offer a more precise approach to fighting cancer, less like using a sledgehammer and more like using a scalpel, wouldn't you say?
They definitely hold a lot of promise. CAR T-cell therapy, for example, it's really quite ingenious. It's like we're giving the body's own immune system a turbo boost, training it to become this this highly specialized cancer-fighting force. The process involves actually collecting a patient's T cells, which are a type of white blood cell, and then genetically modifying them in the lab to make them more adept at finding and destroying those cancerous cells.
So instead of just throwing a bunch of powerful drugs at the cancer and hoping for the best, we're essentially teaching the body to fight back on its own, but with much greater precision.
That's the gist of it. And because it harnesses the power of the immune system, it holds the potential for longer-lasting remissions, maybe even cures for certain patients. It's quite remarkable when you think about it.
It really is. And how about targeted therapies? We hear that term thrown around a lot these days. How do they fit into all of this?
Targeted therapies work a bit differently. They're designed to exploit specific vulnerabilities within those cancer cells. Imagine them like, well, like guided missiles, homing in on their target while leaving the healthy cells relatively unharmed.
So, greater precision, potentially fewer side effects. That sounds like a game changer, especially for patients who are already so critically ill.
Absolutely, and that's the hope. But it's important to remember that these therapies, they're still relatively new to the scene. We're still gathering long-term data on their effectiveness and their safety, particularly when it comes to using them in these extremely vulnerable patients in the ICU.
So, while these new treatments definitely hold incredible promise, it sounds like we're not quite ready to completely abandon those more traditional approaches just yet, especially when it comes to managing those cancer crises we've been talking about.
That's right. It's a rapidly evolving field, and I think the future is incredibly bright. But for now, it's about carefully weighing the risks and benefits, considering each patient's individual circumstances, and making the most informed decisions we can with the information we have. But who knows? Maybe one day soon, these targeted therapies and immunotherapies, they'll be the go-to weapon in the fight against cancer. And on that note of cautious optimism, I think we've just about covered it for today's deep dive.
It's been, well, a crash course, to say the least, in the world of emergency chemo in the ICU. Intense, fascinating, and ultimately hopeful. For our listeners, thank you for joining us on this journey. Until next time, keep asking those tough questions and stay curious.